Welcome everyone. Thank you for joining us for today's webinar. Today we are presenting, I will introduce myself. My name is Dr. Maysoon Motobbagani, and I am the Technical Director of Microbiology Lab at King Faisal Special Hospital, Assistant Lab Head. Today we are presenting redefining the role of the laboratory professional routine laboratory race against COVID-19 pandemic. It's my great pleasure to welcome Professor Bornali. Professor Bornali, she is the consulting and laboratory division in Berghaben Hospital. She is the executive member, scientist division, International Federation of the Clinical Chemistry Lab Medicines. And she is the chairperson of AAC Indian section and also AFCC committee, also a CAB inspection. It's my great pleasure today to introduce one of the famous in the chemistry sectors. Just before we start our presentation, please, if you have any questions, you can type it in down in your webcam. And also, at the end of our presentation, there is a room for all your questions, and Professor, she will answer it. Now, without our further delay, we will turn our mic. Myself, I will turn my mic and welcome Professor Bornali.
So today I will share with you the story of lab professionals redefining role of the lab professional, routine labs race against this COVID-19 pandemic. So let's see how. And thanks to Dr. Maysoon for this kind introduction, and thanks to Saudi Society for Clinical Chemistry and Lab Medicine for inviting me and giving me this opportunity to talk and share my experience with esteemed delegates. And thanks, Professor Dr. Samia Sobki, for this kind invitation. So for us, the diagnostician, every blood sample tells us a story. So today I will share our case history in Kokilaben Dhirubhai Ambani, few case history in Kokilaben Dhirubhai Ambani Hospital, and also international, being a executive committee member of scientific division of International Federation of Clinical Chemistry and Lab Medicine, IFCC. So IFCC given directives for routine labs role in this race against this pandemic. Also being a chair of AACC India section, I'll share with you the AACC's directives on this COVID-19 pandemic. So during our lockdown time, this was my painting during the lockdown time. If you see, there is our RT-PCR, autoanalyzers, microscope. We are in lab, we are doing all those things, but always we lab professionals try to be in the background. But this COVID-19 pandemic actually changed the whole scenario. So now the lab professional roles is the main, and we are, if you see this extended hand who are helping the clinician, the intensivist, the A&E physicians, or the ICU physicians, these are our hands. So we are acting like a true healer during this pandemic. Let's see how. So this is one case history of 67-year-old male, known case of diabetes, hypertension, chronic kidney disease on maintenance, hemodialysis. So COVID-19 positive on routine evaluation. There was no history of contact, no history of travel, and clinical features was very high-grade fever, breathing difficulty, chest X-ray showed bilateral infiltrates. So if you see the lab parameters, you can see interleukin-6 was 650 picogram per ml, CRP was raised 17 nanogram per ml, procalcitonin was raised 2 nanogram per ml, high sensitive troponin I was 45.9, it was raised, and liver function test was deranged. And if you see the D-dimer is around 3000 nanogram per ml, ferritin raised more than 40,000, LDH is raised, and CPK and creatinine is raised, BUN raised, ABG deranged, lactate increased, and if we come to the CBC parameters, there is leukocytosis, neutrophil count is increased, lymphocyte is decreased, so NLR ratio or neutrophil lymphocyte ratio is deranged, and platelet count showing the thrombocytopenia. So this is our scenario in lab, and because of that, this is a case history in our lab. And if you see COVID-19 or coronavirus 2019 is a global pandemic now, and it's caused by severe acute respiratory syndrome, coronavirus, SARS-CoV-2, and the coronaviruses are enveloped protein sense RNA virus, diameter ranging from 6 nanometer to 140 nanometer. This all of us know, but I am just for the sake of completion, I am telling this. And it has spike-like projection on its surface, giving it a crown-like appearance under the electron microscope. So as we know the history, severe acute respiratory syndrome or SARS coronavirus, it was there in year 2002, and coronavirus of beta genera origin in bats, and it was emerged from China, and around 8,000 people affected, mostly in China and Hong Kong, and around 916 deaths. Mortality rate was 11%. And MERS-CoV in year 2012, bat origin, and emerged in Saudi Arabia, and where there was a camel was the intermediate host, around 2,494 people affected and 858 deaths, and fatality rate was 34%. And now in year 2019, we have this coronavirus disease 19 or COVID-19. So in late December 2019, Chinese health authorities investigated a cluster of atypical pneumonia cases occurring primarily in individuals who has visited the seafood and wet market of Wuhan. And in December 31st, 2019, China notified that outbreak to the World Health Organization. And the first fatal case was reported on 11th Jan 2020. So the emergence of novel coronavirus disease or COVID-19, testing for common cause of respiratory infection yielded negative results. Sequencing of the bronchoalveolar lavage fluid identified variant of beta coronavirus, and the virus was subsequently isolated in eukaryotic cell culture. And the virus is distinct from the SARS-CoV and MERS-CoV, and with the sequence homology of approximately 79% and about 50% respectively. So WHO named it as a SARS-CoV-2, and the virus since then spread from China to other regions of the world, and we all are fighting and we are chasing this pandemic. So this is mainly for person-to-person transmission through respiratory droplets produced when an infected person coughs or sneezes. People are thought to be most contagious when they are mostly symptomatic, but transmission is also possible during non-symptomatic phase or asymptomatic phase, usually 4 to 6 days or 2 to 3 days before the onset of symptoms. So spread also from contact with the surface that has the virus on it and touching the mouth, nose, or eyes. The incubation period is 2 to 14 days. And blood, urine, stool, and body fluids other than the respiratory secretions are thought to be lower risk, but the virus has been isolated from these fluids in patients with COVID-19. Now coming to the clinical presentation, we know the variation in the clinical presentation. Recently, like today, one of my friend presented with deafness and came SARS-CoV-2 positive by our RT-PCR. So we know the variation in the clinical presentation. So as per CDC, people with COVID-19 have had wide range of symptoms ranging from mild to severe illness. So many people are asymptomatic. Major symptoms are fever, chills, cough, tiredness, muscle or body aches, pains and sore throats, and in some other cases, congestion or runny nose, GI symptoms, nausea, vomiting, diarrhea, skin manifestation like rash, neurological manifestation, headache, new loss of taste or smell and deafness. Many other presentations are possible. And other serious symptoms or visible emergency warning signs are difficulty in breathing, shortness of breath, persistent chest pain or pressure in the chest, new confusion, inability to wake or stay awake, bluish marks on the lips or face. So CT findings, we see ground glass opacities with or without consolidation. And the clinical presentation has an effect on the respiratory system, leading to the rapid development of pneumonia. It also leads to acute respiratory distress syndrome. And why this is happening? Because early in infection, the pathophysiology of that, SARS-CoV-2 target cells such as the nasal and bronchial epithelial cells and pneumocytes through the viral structural S protein or spike protein that binds to the angiotensin converting enzyme 2 receptor or ACE2 receptors. If you see this diagram, and there is type 2 transmembrane serine protease or TMPRSS2 present in the host cell, promotes viral uptake by cleaving ACE2 and activating SARS-CoV-2 S proteins, which mediates the coronavirus entry into the host cell. So ACE2 and TMPRSS2 are expressed in the host target cells, particularly alveolar epithelial type 2 cells or type 2 pneumocytes. And if you see, there is viral entry into the cell, and then there are multiple variants, and then you can see the cytokines are released, and T lymphocytes and monocytes are also released into the cell, and there is hyaline membrane formation and microthrombi formation. So this is the pathophysiology of the disease. Now coming to the lab's role. Of course, the lab roles is like Dr. Masoon is there. The primary role is diagnosis by RT-PCR, and but the roles of routine lab, the role of biochemist, role of hematologist, role of the other lab physicians are not less. In after the diagnosis, in prognosis, in biochemical and hematological monitoring, and also in therapeutic monitoring. Like suppose person is given tocilizumab IL-6 receptor blockade or remdesivir. So the therapeutic monitoring, the routine lab plays a very important role. So staging, prognostication, and therapeutic monitoring, the routine lab parameters or hematology or biochemical parameters play a very important role. And then the epidemiological surveillance, the role of anti-SARS-CoV-2 antibodies, IgM antibodies and IgG antibodies, role of epidemiological surveillance is very important. So the lab's critical role, of course, the etiological diagnosis of SARS-CoV-2 is the most essential role. And then WHO, CDC, along with other national and international scientific organizations like IFCC, AACC, and in India, we have ICMR, and in your society, the National Society, play a very important role to give the directives. They timely release the detailed information for diagnosis of SARS-CoV-2 by reverse transcriptase polymerase chain reaction, RT-PCR, which test kits are important, which test the sensitivity and specificity of the test kits, and then the antibody testing, antigen testing, rapid antigen testing. So directives, the national and international organization are playing a very important role in giving these directives. And then availability of the licensed diagnostic kits and uniformity of the testing protocols across different nations are important aspects for providing a clear and reliable epidemiological picture. And of course, patient monitoring, staging, therapeutic monitoring, and prognostications, routine lab play a very important role. Now, what are the common parameters, routine lab parameters, which we see to measure the severity or predicting the risk of evolution towards ARDS or DIC or disseminated intravascular coagulopathy. So for that, lymphocytopenia, increased values of CRP or C-reactive protein, increased LDH, increased ESR, increased D-dimer, diminished concentration of serum albumin, as I have shown in the case I have described, and predict the progression towards the severe or critical form of COVID-19 like leukocytosis, neutrophilia, lymphopenia. NLR ratio or neutrophil lymphocyte ratio play a very important role. Then increased values of LDH, AST, ALT, total bilirubin, creatinine, cardiac troponins, D-dimer, prothrombin time, APTT, procalcitonin, CRP, interleukin-6 play a very important role, and decreased values of serum albumin and total protein. So if we see, this was one paper by Dr. Lippi and Dr. Flebani. So they have shown in around 1,000 patients, the lymphopenia was present in 83.2%, thrombocytopenia was 36.2%, CRP around 60%, LDH 41%, AST, ALT around 20%, D-dimer 43%. And this is our study where we have seen, because our was we have in Kokilaben Dhirubhai Ambani Hospital, this is a critical ICU we have for the COVID-19 patients. So we have seen in our patient mostly interleukin-6 are increased, and ABG is deranged around 82% cases, CRP around 86% cases, procalcitonin around 69% cases. Troponin anti-proBNP was measured in severe acute case who were showing the myocardial damage. So they were also very much raised in, and then coming to the neutrophil lymphocyte ratio, and neutrophil was increased in 67% and lymphocyte was decreased in 83% cases. And creatinine was around 41% cases was decreased. So this is our current scenario, and this is the recent paper where you can see different stages of the disease, where early stage or inflammatory response, where we say initial stage eosinopenia, lymphopenia, and in early stage we see CRP increase, ferritin increase, LDH increase, D-dimer increased, fibrinogen increased. And then the late stage where organ damage starts, we see cardiac troponin I increase, NT-proBNP raised, where there is a heart failure, liver enzymes are increased, and there are neutrophilia, and anemia also is seen around week 2 and week 3. So this is the progression of the disease. And labs role in surveillance like anti-SARS-CoV-2 antibodies, both immunoglobulin G and M. So although the serology testing cannot be replaced by RT-PCR, this antibody testing are not for replacing the RT-PCR, but antibody testings are for the surveillance test and for the widespread application of this and other rapid serological tests may hence enable to gain valuable epidemiological data to fight against this viral epidemic. So they're coming to the biochemical monitoring. The essential role of clinical laboratories in this pandemic extends far beyond the etiological diagnosis, because we need to know about the disease progression. We need to know about the staging. We need to know about the therapeutic monitoring. And as we know, the cytokine storm, and when the storm is raging, the cytokine tests like interleukin-6, ferritin, which are suspected increased during suspected hyperinflammations, these are raised. So why when we see the complete blood count deranged, leukocytosis, neutrophil count increase, lymphocyte decrease, or decreased platelet count or thrombocytopenia. So these are seen in bacterial superinfection and also decreased immunological response to the virus. And also in consumption coagulopathy, we see that D-dimer raised and albumin is decreased, then ALT is raised, AST raised, total bilirubin raised when there is organ damage, liver injury, and creatinine BUN raised when there is a kidney injury, cardiac troponin raised, cardiac injury, and D-dimer prothrombin time are raised due to the activation of the blood coagulation or disseminated coagulopathy. And procalcitonin is another important marker when there is a bacterial superinfection, and CRP is the early marker in severe viral infection, viremia, or viral sepsis. And ferritin is raised again, it is a pro-inflammatory, and it's increased during the severe inflammation. And when there is a cytokine storm and storm is raging, to tase the storm, we need to do the cytokine test like interleukin 6. So interleukin 6, let me tell you the story. When in March we started the testing interleukin 6, one fine Sunday morning, I got a call from our intensivist that, Barnali, I need to start interleukin 6. I said, suddenly from where I will arrange interleukin 6 kit? Then they said, no, I need immediately, you have to give me the interleukin 6 result, because I have a physician in my ICU, and we need to start tocilizumab. So before that, I want to do the interleukin 6. So I arranged the kit from the warehouse, and then did the verification or the validation of the emergency validation. I called College of American Pathologists to do the emergency validation, because I can't wait to do the test for 5 different days and around 20 days before starting the test. So because of that, I have to do the emergency validation of the test. So interleukin 6 is severe COVID-associated pneumonia patients with features of systemic hyperinflammation designated under the umbrella term of macrophage activation syndrome, or MAS, or cytokine storm, also known as secondary hemophagocytic lymphohistiocytosis, or secondary HLH. The COVID-19 infection with MAS, or macrophage activation syndrome, typically occurs in subject with adult respiratory distress syndrome, or ARDS, and non-survival of ARDS was linked with sustained IL-6 and IL-1 elevation. The potential impact of timing of anti-cytokine therapy, or like tocilizumab, where there is an interleukin 6 receptor blockade or viral clearance, we need the test like interleukin 6. So what is the difference? Because we see classical macrophage activations or syndrome organ pattern, and also the COVID-19 related macrophage activation syndrome. In classical MAS pattern, we see organomegaly, but there is no spatial tropism for the pulmonary tissues. There are, in classical macrophage activation syndrome, we see lymphoid organ hyperplasia, hepatosplenomegaly, and adenopathy. But in COVID-19 related macrophage activation syndrome, or secondary HLH, there is no classical organomegaly pattern or hepatosplenomegaly. We see the pulmonary tropism it is more confined to the lung parenchyma, and immediately adjacent bronchial alveolar lymphoid tissue is associated with the ARDS development. So here in severe COVID-19 associated pneumonia, we see severe widespread alveolar interstitial inflammation extends to the closely juxtaposed pulmonary vasculature. So there is elevated D-dimer, and there is DIC kind of, or pulmonary intravascular coagulopathy presentation. So where we see high elevated CRP, hyperferritinemia, then other features including coagulopathy, abnormal liver function, and cytokines are increased, especially we have seen interleukin 6 is raised. And severe COVID-19 associated pneumonia, we see this liver function, different organomegaly, liver function test deranged with coagulopathy, and the COVID-19 pneumonia patients have serological markers associated with MAS development, including increased ferritin and D-isocyne, D-dimer, and D-isocyne of picture. So we see this kind of picture. And if you see, this are the no symptoms, and this is the mild symptoms where interleukin-6 is raised, and there are lymphopenia, and when there is severe COVID-19, there are fever, cough associated with fatigue, myalgia, dyspnea, ARDS, and respiratory failure. And here we see LDH increase, D-dimer increase, CRP increase, ferritin increase, IL-6 increase, and along with the procalcitonin and decreased lymphocyte, decreased CD4 T cells, CD8 T cells, and WBC increased. So coming to the myocardial, cardiac or arrhythmic complications in patients with COVID-19, we have seen a major increase in high-sensitive troponin I or troponin T in COVID-19 related myocardial injury. Myocarditis is a present myocardial injury, and arrhythmia is the presentation, because cardiac manifestation etiology seems to be multifactorial, comprising direct myocardial damage, hypoxia, hypotension, enhanced inflammatory status, ACE2 receptor downregulation, among the others. So if we see the decompensated heart failure, because of that, we see NT-proBNP raised, acute coronary syndrome, where we see myocarditis, we see high-sensitive troponin I raised. And coming to here, we see, if we see MARS, and previous SARS, there was no HS troponin I increased and NT-proBNP increased. But in SARS-CoV-2, we see the myocardial injury marker are increased, like high-sensitive troponin I increased and NT-proBNP increased. Then coming to the neurological presentations, we see central nervous system manifestations like disease, headache, impaired consciousness. Like I told today, my colleague has deafness due to COVID-19, and then peripheral nervous system manifestation, taste impairment, smell impairment, vision impairment, and skeletal muscle injury manifestations. So there are different kind of presentations. So this is one case of 56-year-old physician, and history of fever and colds in 6 days associated with cough with expectorant, and history of severe body ache, decreased appetite, mild hypertensive, history of contact suspected, because he was physician, he was treating the patients, and they were suspected patient. And history of similar complaints in close family. He started hydroxychloroquine on his own on day 3. And he was physician in some other hospital. He was brought to our hospital, and day 6, our RT-PCR was positive. And if you see different markers, the liver injury markers, ALT, AST raised, then albumin decreased, triglyceride increased, and the coagulopathy, then D-dimer increased, ferritin increased, LDH increased, CPK raised, ABG deranged. If you see, the SO2 percentage was 72.4%, CRP was 21, interleukin-6 was 126. This was a picture. This is a case, I think, in March 2020. And if you see the CBC, NLR is deranged, lymphocyte is decreased, leukocyte increase. So that time, initial treatment, they started with paracetamol, ceftriaxone, and hydroxychloroquine, but there was persistent high fever. Day 9, there was increasing CRP, increasing ferritin. They started lopanavir, ritonavir, single dose, but stopped due to high QTC interval, and then the fever was increasing, and it was 104, and then this patient was desaturating even with oxygen 1 liter per minute. Chest X-ray showed bilateral infiltrate, CT scan showed ground glass opacities. The cytokine storm is raging, high fever, increased D-dimer, ferritin, LDH, interleukin-6. So there is acute lung injury. So they thought, after that, they thought, let us start the tocilizumab, interleukin-6 receptor blockade, 400 milligram, and repeat dose after 1 day. But with tocilizumab also, the fever was persistent, inflammatory markers raised, oxygen requirement increased. Then there was then they started methylprednisolone, the steroid, 30 milligram twice daily for 3 days. After that, no fever, decreased clearly no oxygen requirement, patient was discharged. This is like how the markers evolved, and based on our lab's role, our routine lab parameters, the clinician decides the cytokine storm is raging and decides about the prognostications. So this is another, pediatric multisystem inflammatory syndrome, or PIMS. You must be hearing this often. This is in the children. We see the PIMS kind of picture. This is a 14-year-old female. Fever since 3 days, rash since 2 days. There was SARS-CoV-2 positive, no history of contact, no history of travel, fever, persistent oliguria, tachycardia, hypotension. Our RT-PCR was positive, and total immunoglobulin antibody test was also done, and it was also positive. And if you see the different days picture, and if you see the trend analysis, if you can see the IL-6 raising, D-dimer is raising, and along with other markers, and CBC is deranged. So we do the monitoring of these routine lab markers, helps us to do the trend analysis, helps us to monitor and prognosticate the patient. So this is pediatric inflammatory multisystem inflammatory syndrome in children, or MISC. So this is it caused by COVID-19? Of course, yes. And this is well described, is actually presents like Kawasaki-like disease or toxic shock syndrome. And some have referred this condition as Kawasaki-like disease. And here, actually, it's linked to COVID-19 because most of the children either have SARS-CoV-2 positive by our RT-PCR, or antibodies positive, or sometimes both of them are negative, but there are history of contact. So we see very small number of PIMS cases, and actually it's uncommon, but now in India we are seeing many cases of PIMS, and it's actually Kawasaki affects under the age of 5 years, but PIMS associated with COVID-19 we see in teenage, and this is presence like Kawasaki-like disease and toxic shock syndrome. There are organ damage, and it affects the older children with gastrointestinal syndrome symptoms, and the greater chance of damage to the heart and kidneys. So now coming to the lab roles, wow, what is this? Like A lab is giving the POC antigen testing negative, B lab is giving RT-PCR positive, and another lab is giving IgG antibody testing positive. So with this 3 kind of reports, when one patient goes to the physician is thinking which lab result to believe. Should I believe the POC antigen test, or should I believe the RT-PCR, or should we believe the body test is positive? What to do? So this is our common lab scenario. We are, if you see the patients are coming with burden of disease, we are using our intelligence, discipline, and creativity, and patients are going with a report. Either they are happy or they are not happy. Or you can recognize you or me. We sometimes act as an enabling SSR or College of American Pathologist inspector. We go to one lab for 1 day, or we do the audit or inspection, and based on that we say, oh, this lab is fit for doing the test of our RT-PCR or antigen testing. So POC antigen testing negative. If it is negative, we need to, if there is a clinical suspicion, we need to do the test by our RT-PCR. And here in India, if POC in the antigen test is positive, we can take that as a positive, but negative antigen test, if there is a clinical suspicion, we need to confirm by our RT-PCR. And so this is like, why standardization and harmonization, International Federation of Clinical Chemistry and Lab Medicine, IFCC's role, like they have this task force for standardization and harmonization. So I believe I want to end. I think I have finished my timing. So I believe in the philosophical lines of Albert Einstein, life is like riding bicycle. To keep your balance, you must keep it moving. So how to harmonize the lab diagnosis in COVID-19, how to chase this COVID-19 patient, or how to chase this pandemic. We need this to know about accuracy, precision, cutoff, linearity, sensitivity, specificity, and also the arm of cost, man, 3 magic M's, man, machine, and material are very important. And who will do this balance? Standardization and harmonization will balance between these two arms of these two wheels of the cycle, and I think we can have a smooth ride in our lab, or smooth lab life. Thank you.
Thank you, Dr. Bernali. It is a really excellent presentation, well information. I believe with you that molecular lab alone, it's not patient care. I'm sure that we are all together provide a best service care. I start with myself. I have one question to you. As a microbiology, we just report the PCR, RT-PCR COVID positive with CT value. Did you correlate the CT value with any marker like CRP or D-dimers? Or because sometimes we find that the viral load is very high. Is it related? Is the D-dimers or C-reactive protein high as well? Did you do any correlation between the CT value of the virus?
Yes, we have done with, not really to publish, but we have done for the CT values. Actually, in India, the directives are initially the ICMR directives was that we should not give patient the CT values. But we have done, like when we started, we have started reporting with the CT values. That time we have done with the D-dimer and CRP basically, because those are the initial like admission protocol. And then we have seen that correlates with the CT values where there is a high viral load, and then it correlates D-dimer, and specifically CRP correlates well with the CT values.
Okay, thank you. There's a lot of comment about excellent lectures, and there's one question is, how do you see the role of bronchiolitis as a prognosis and biomarker in COVID?
Titers?
How do you see the role of bronchiolitis? Because the line is just my affliction, and maybe you can see it. And prognostic of biomarker in COVID.
Okay, can I see the question? I didn't get this thing. Procalcitonin, how did you roll up procalcitonin?
Yes.
Okay. Prognostic, role of procalcitonin as a prognostic biomarker in COVID. Yes, when there is a bacterial superinfection, we have seen, like we have done, actually we published also one news article on procalcitonin in COVID-19 as a prognostic marker. Initially, the mild and moderate cases, we have not seen procalcitonin raised. Usually procalcitonin remains between 0.5, but when in a severe cases, when there is a bacterial superinfection, we have seen the procalcitonin in the range of 2 to 5. But we have not seen procalcitonin like, but we see more than 20 or more than 50. We have seen in COVID-19 patients, even with bacterial superinfections, the procalcitonin, the values are between 2 to 10. And this is a prognostic indicator and prognostic marker, because it says that this is a marker for bacterial superinfection. So they can actually, this is a marker for antibiotic stewardship too, when there is a sepsis, along with viremia, where there is a bacterial superinfection.
Okay. Thank you, Dr. Bernai, because we're starting late. I'm sure
and I'm sorry for the technical hitch, and thank you so much for your kind invitation, and thank you so much. So many esteemed delegates that joined. It's my privilege to present in front of all of you.
And we have a lot, about 969 audit. Yes, and thank you so much, Dr.
Really privileged.
Okay, I would like to introduce the second topic, which is one of my favorite topics. It's utilizing artificial intelligence, health technology, potential in COVID-19 pandemic. My great pleasure to welcome Professor Dabalia. He is the professor, Dabla, I'm really sorry, I keep saying Dabla. Dabla, Professor Dabla. He's a professor in Department of Biochemistry, and he is a medical in the educational and research. Also, has a consultant in a lot of committee, AB, FCBA, and also in a Nepal Medical Laboratory for Clinical Chemistry. Today, our topic is about the artificial intelligence, which is the future of 2021. We will welcome Dr. Dabla and start, please.
Thanks a lot to Dr. Masoon and the president of SSCC Society of Saudi Arabia for inviting me as the speaker for this particular webinar. And thanks a lot to Dr. Banali as well, giving such a fantastic presentation about the importance of laboratory in, fighting this COVID-19 pandemic. Because whatever the clinicians are doing, that in probably in every state or in all the global regions, the lab is one which is always sits behind. But I see that laboratory is very important part of any hospital or healthcare industry, because this is the heart of any hospital. So let's go ahead with the topic. So this is my institute, the JEPA, GB Pant Institute of Postgraduate Medical Education and Research, where we are serving patients almost from all the North Indian region and beyond that, for treating the cardiology, neurology, gastroenterology, psychiatry, and many more specialties. So I'll be discussing my slides into the headings of the brief facts about the COVID-19, the role of AI in the modern world, and mobile apps in healthcare and how it works and how they are helping. I mean, the mobile apps are helping in fighting against the COVID-19, and we'll end up with a summary. Before we go ahead, Dr. Maison, how much time we have right now? So we can go accordingly.
I think since we can have until 7:15, like another half an hour, we can extend it. I think so. I will ask the coordinator, but they start doctors, and I will ask them separately.
Okay, thank you so much. So in the era of, welcome to the era of COVID-19. So as you can see directly to the slide, we all are looking for this SARS-CoV-2, what exactly this new virus is. So as Dr. Banali has already explained that it was identified first in Wuhan with the people, those who are coming with the features of pneumonia, and probably started in animals, but now spreading between the humans. And now let's see the different the types of the human coronaviruses. It is a large RNA viruses which is spherical in shape, and they are helical capsid with a lipid envelope, and they can directly multiply in the host cell due to the presence of the RNA polymerase. And there are the different 7 strains of the coronavirus has been identified till now, where this COVID-19, the CO stands for the corona, VI stands for the virus, and D for the disease. So this SARS-CoV-2 is a coronavirus which is belonging to the family of coronaviridae. Now, again, the understanding of this mode of transmission is still, it's growing, and we are, getting the information, because the information about this new virus is quite dynamic, and we are getting the research papers and informations through the agencies in a different manner, and we are collecting, and we are trying to collect all the information to have some more information about this virus. And this respiratory infections can be transmitted through the droplets of the different sizes. And when we say the droplet particles are more in size, like more than 5 to 10 micrometer in diameter. They are referred to as the respiratory droplets. Whereas when the size is less than 5 micrometer in diameter, they are referred to as the droplet nuclei. Now, what is droplet? Because we are, learning more about the droplet when we are talking about the COVID-19. So these are the droplets are the which has been spread through the respiratory secretions and maybe through the coughing and sneezing, and they are landing onto the mucosal surface like the nose, maybe the mouth and the eyes, and we are catching infection through those mucosal surface. Droplets, though, typically do not travel more than the 6 feet, about the 2 meters. So that is why we ask to keep a distance of at least 2 meters. Now the common symptoms, of course, as Dr. Bernardi explained, that the fever, the dry cough, the breathing difficulty. Now, depending on to the comorbidities involved with the patients involved, it can extend it to the the cardiac complications. Maybe the CNS is also involved, along with the respiratory symptoms. So more or less the primary symptoms are the muscle aches, the pains, the nasal congestion, and the sore throat or the diarrhea.
Pardon me, Doctor, Professor, because we cannot extend. We have only 15 minutes. I'm really sorry.
Okay, so not going to the WHO COVID-19 dashboard that you all can go and can see that, but yes, it has extended a lot. The global total population has extended to about the 43,341,000 and 451,100. Now, coming directly, what is artificial intelligence? So it describes a range of techniques that allows computers to perform the task typically thought to require the human reasoning and the problem solving skills. Thus, processing a large amount of the data, which are helping us to recognize the patterns into the data which is coming through the different layers of the deep neural network. That is we also call as the Internet of Things. Now, as you can see into the slide, historically it has been started in 1950 with the US agency, that is the Defense Advanced Research, the project which has started mapping the street cameras in 1970. So it is having a large long history, and now we are using the Siri, the Alexa, which are again the household names. Now coming to the picture, as you can see downwards, as you can see, just an example that we are trying to identify the cat. So as you can see, the neural network help us to identify on screen the image of cat, which is going to through its different morphological features going to go through the different neural network, and it is helping us to identify with some probability. So to identify with that particular morphological features, it can be 97% is going to identify as a cat, where the 1% is a dog, or maybe 2% as the another animal. So this is we call as the neural network. I'm going to explain it further. Now the artificial neural network is a common type of machine learning which is inspired by the way that our human brain works and how the neurons are interconnected with each other, to passing that particular information. So starting from the left, as you can see, this is the model to identify the cancer cell, and we are having the different inputs of the morphology, the height, the stiffness and thickness of a cell. And again, they are connecting to the different of layer of our model is in yellow. So the arrows that connect the dots shows neurons are interconnected, and however the data travels from the input layer and through the output layer. That we call as the example of the machine learning. Now, how this AI matters in this modern world? Of course, we are working and we are using the AI algorithms in different manner with the real-time data information through the sensors, through the digital data, through the remote inputs, and for example, the Google Map is again very fantastic example that we are using in our everyday life. And coming to the important part, the plagiarism checkers. So what we do in routine in this plagiarism detection, that we are going to detect the regular text which is available in the massive database online. However, this machine learning, if we going to put with the plagiarism checkers, is going to help us to identify the sources which are not located within this database and may be available into the different foreign language, or maybe to some older sources that have not been digitized. And again, the Facebook is also a very fantastic example that we are using as the social media. Now, how the AIs has been evolving the biomarkers and with the technology. As I've explained, the machine learning is a subset of artificial intelligence algorithms, and it is related the ability of to learning from a large amount of data. Whereas the term AI is often being used interchangeably with the machine learning, but yes, the machine learning is a subset of AI. Now, the input data in that case can be quite varied, which may be ranging from the social environmental to the clinical laboratory data to the omic data. And giving an example, there's one of the literature being published in this year 2020, where the Mirantrex, which is a German company, has applied the deep learning methodology for the medical issues. And they have they applied the artificial intelligence with the medical imaging, that is detecting the lymph nodes into the human body based on in CT scan images, thus even identifying the small lesions or the growths that could be problematic. And of course, in the cardiology, AI has shown to be fundamental tool for the clinical practice of the cardiology, also for the biomarkers, and also a lot. This is the article or the paper kind of being published by the Committee of Mobile Health and Bioengineering. I'm also a member of the same committee, and they have where we have tried to give a review of the artificial intelligence and its integration with the precision of the cardiovascular medicine, its diagnosis and its prognosis, and the development of the biomarkers. Again, one more very good example of the AI in the prediction of the mental health disorders. This paper was published. By the Kramer, Kozik et al. In the Croatia Medical Journal in this 2020, where they have as we know that the COVID-19 is posing a serious threat to the mental health of the healthcare workers. Those who can develop have the elevated anxiety, maybe the post traumatic stress disorder, maybe the depression, or even going through the suicidal behavior as well. In such circumstances, one of the greatest impact of digital psychiatry is to pose the machine learning during this COVID-19 pandemic. And they have proposed a methodology where they have described into the 5 phases, which is including both the objective assessment, the subjective assessment with the questionnaire, and with the distinct simulation paradigm design with the statistical and the machine learning data analysis. Combining all those 5 steps, they're going to give the concrete analysis of the healthcare workers or anybody who's going to going through that particular process. So they're going to giving this diagnosis more quickly and accurately and rapidly, thus providing the optimal treatment for the patients. Hope you guys can hear me.
Yes.
Thank you. So now going to the last, to the next is mobile health. Now, uh, when in this pandemic we are being caught into the situation where we are, doing the lockdown, where when we were not able to come out of our home. So it is the mobile health, which is, the mobile applications which are, coming to the major rescue, whether it is related to the grocery, education, healthcare, or entertainment, whatever. Still, we are also facing the same things. Now, in that case, the mobile apps or the mHealth is an abbreviation that we use, a term which is used for the practice of the medicine and the public health, which is supported by the public devices, and we use the, in reference to the communication devices, such as, the mobile phones, the tablet, or the computers that we are using into the healthcare services and for the information. And these apps are, helping us for collecting the community in the clinical health data, delivery of healthcare information to the practitioners, and, the real-time monitoring of the patient vital signs, and so on. Now, this is again how this mobile apps being, being utilized, and it's growing its market. And this is one of the literature which is being published in the Business by London in 2020, where they have stated that it is expected to, this market of mobile apps is going to, expected to grow by the US dollars 497 billion by the 2020 to 2024. This paper or this literature was published by the status report by the Technavio. So you can see the mobile apps are having, the lot of potential in utilizing for the healthcare and for the patient care as well. Now, there are a few examples of the mobile apps which are being utilized earlier, beyond this era of the COVID-19, and this those
Professor, I'm really sorry. We start running out of time. One more minute. Sorry.
So I can't help it. So you tell me where to stop, because I have a few more slides to go. So
okay.
Okay, so mobile apps, as you can see, they are the mobile apps which are already available with the medical records, clinical decision making, and more. And remote patient monitoring is a part of the mHealth, which is, is a technology which is enabling the monitoring of the patients outside of the conventional clinical settings. Now, how this works, this remote patient monitoring is working with the help of, we also call as telehealth, and it is, working on a cloud based connecting system. As you can see through this slide, that the information through the of the blood pressure, of the blood sugar, of the ECG is going through the cloud network, through the Bluetooth network, and is going through the practitioners, where they're, advising for the patient care further. I'm going slightly faster, so I don't have a time. Sensors is again being technology being utilized into this remote patient monitoring. Bluetooth technology, as I explained, that is a wireless connectivity standard which uses the radio signals, and it is being considered more better, and they virtually have no power, and because they don't travel so far, so theoretically they're more secure than the wireless networks. There are a few examples of the apps which are being utilized for the healthcare system. The few examples again of the smart-based COVID-19 testing, one of the very innovative, the potential of the smartphone-based COVID-19 testing. One being developed by the Sanofi with the Luminex, where they have developed the home this home test for the COVID-19, and it is based on to the nanoparticles. When they come in contact with the virus, they glow, and this picture can be uh, captured and can also be shared with your treating physician. MD Bio COVID kit. The apps being also been developed by the New York University College of Dentistry, where they have they have used the biomarkers to determine the severity score, and they have trained the model using the machine learning algorithm, and being started first being used in China and then being validated in US itself. Again, Dr. Bernali has explained that what is the ground glass opacity, which is a quite very fantastic feature to have the diagnosis, or we can say the screening of the COVID-19 patients. So this particular feature being utilized by the handmade, which is the AI based handheld X-ray camera, which they captures the picture with less than 3 seconds per scan. So what happens that a handheld camera is going to take the picture and is going to give that particular picture is associated with, again, this convolutional neural network algorithm, which is again going to give the diagnosis of that patient. And this particular technology is being trained over in more than 1.5 million chest X-ray data. So it gives the integrated. It is a very good example of the integrated telemedicine. Geolocation is again, and the contact tracing being utilized into the various countries, and is again a part of the mHealth. And this is the technology which works with the GPS chip based technology, and that uses the trial iteration technology, where they say, for example, if you want to know the specific location of a person. So out of those 27 satellites which are available and working into the atmosphere, I mean, they choose the nearest 3 satellites, and they do the approximation of these 3 satellites with the location of a person, and going to give you the one's exact position. These are the apps being used for the contract tracing, for the information providing, for the education, and for the many purposes. And more or less, if I say, these are being utilized for the purposes like self-assessment, the contact tracing, multi-purpose apps, and the apps being utilized for the resource management as well, being utilized into various countries. WHO Academy is also using its mobile learning app for the education of the healthcare workers, and this particular app is available for free, and it is available into the 7 languages. Now there are different challenges to face, because yes, we are using the artificial intelligence into the various other fields, but yes, into the healthcare, this is very new, and we also trying to utilize this technology for the patient care. So the reliability of this data is again a very big question that comes when we are thinking of the AI, and to utilize that particular technology and the outcome with the clinical decision making. Protection of data, the privacy is very important in care of a healthcare, I mean in case of healthcare industry. Impact of doctor-patient relationship, I mean how it is going to perceive when we are going to utilize that particular technology onto the competency of a doctor, accuracy to the patient management, medical legal complications, ethical implications are also there. But yes, the agencies are being working out into the various countries. Likewise, I've given an example of the FDA, where they have given the policy for the device software functions and the mobile medical applications guidance being updated in 2013, and first issued in 2013 and updated in further years as well. Um, okay, I cannot see my cursor. Okay, so at last, I know that I was very fast. I could not give you time to explain the intricacies of this artificial intelligence and mobile health, but that
No,
of
you can
course.
go ahead. We extended the professor. You can give us an example. At least we have another 10 minutes, for example.
I'm
We
sorry, but I
extended.
think I have already come to the end.
It's
So
okay.
I must say that with the laboratory, the cooperation and close communication is the key. Um, I myself being a medical doctor, I've also seen that the laboratory is being considered as a third party when we are talking about the patient care. But yes, in current scenario, when we are doing the evidence-based medicine, we are practicing the evidence-based without the laboratory, which is holding the 70% of diagnosis. So there's a need of growing cooperation between providing the guidance on the test selection. Again, into the COVID era, we are coming through the many literature and new upcoming things, and also for the interpretation of the analytics. So, well, thank you so much to the society and Dr. Maysoon and other participants for giving me a time and listening to me. Thank you so very much.
Excellent presentation. Excellent presentation.
Thank you.
Thank you so much. And again, I apologize for the time. And this is the artificial intelligence that we try to have a webinar from different country, and we're limited with the time. Thank you again, Professor Benali and doctors, professors. I think all this artificial intelligence and all the application, it's need a smart, and still not everyone has a smartphone. Maybe by 2024, everyone will get one. I don't know, I have to go if there is any questions in the audience. I'm just flipping and see if we can. Everybody say thank you very much for the information you have provided to us about intelligence and highly required in the country area. I'm sure that everything is changed now with the COVID-19, our life, the way we're thinking, and we start get things together. In Saudi Arabia, we have this kind of application. It's called Tatamman Sahati, where guide you where you do the test and all the information. I'm sure the same in India and same everywhere. Everybody say thank you, and for both of you professors. And before I wrap up, if they want both of you say something to the audience or to us as organizer.
Thank you so much to Dr. Maysoon again, Dr. Samia, the president of SSCC Society of Saudi Arabia, for inviting us to be a part of this fantastic webinar and this fantastic participant. I can see the 939 participants are already there with us, listening to us and giving us time. So I must say that every opportunity, every time gives us the opportunity to learn something new. And what more we can see, this is the best opportunity we are seeing right now. We are connecting with the SSCC and with the Saudi Arabia, the participants through online measures. What more we can see? So we are pushing toward the new measures, toward the new things. We are adopting the new areas. So again, AI is also, I see, is again something that can be pushed forward with this particular era of the COVID-19. And healthcare settings, probably definitely we are needing such kind of technology to go ahead with the time. And again, thank you so very much to all of you, and to Dr. Benali, and to all of you. Thank you so much.
Thank you. And thank you, Saudi Society of Clinical Chemistry and Lab Medicine, Dr. Maysoon and Dr. Samia Sobki, and all the team members of President and all the team members of Saudi Society of Clinical Chemistry. And also thanks to the Snibe Diagnostic for giving us the opportunity to connect with your society. Thank you.
Yes, absolutely. I forgot this Snibe. Yes, you're one of the supporting member of this task of organizing this webinar. Thank you, Snibe. Thank you, Lucy, for inviting us to be a part of this.
Yes,
Thank you
thanks.
so very much.
Hello. Sorry, it is the connection again. There is a few questions. We can still have some time. Let me go through it and I will ask you. I don't know if we can share the questions with everybody because it is like it is disappeared from my screen. I don't know why. I think if the organizers let me one of the questions about what is the test, what kind of test available for COVID-19, which is, I think, she mentioned in her presentation, RT-PCR and antigen testing in India, and also the immunity testing. Okay, there is one question about, I think, for Dr. Bernay, where there is a false negative test for COVID-19 antibody, how determine which is the better manufacturer's antibody? This is, I think, for screening antibody immunity test, serology, or they are talking about antigen for screening. Can you give us some answer, Doctor?
Yes, so for like as Dr. Masoon has said, we have like for COVID-19 testing, we have for diagnosis our RT-PCR and also the antigen testing for as a supportive for the diagnosis, and antibody testing is actually basically for the surveillance purpose. But we see a lot of the pre-analytical error in even in our RT-PCR also we see a lot of pre-analytical error because the collection, like there was one JAMA article, like depending on the collection size, like nasopharyngeal sample or oropharyngeal sample, we see like there are percentage around 70 to 80% of the cases this is positive. And so there are like, you know, collection, storage, transport play a very important role in our RT-PCR. Second, in antigen testings, because sensitivity is a really rapid antigen testing or antigen testing, sensitivity is an issue. So sensitivity of the rapid antigen testing kits, which are currently available, the sensitivity is very less. So because of that, we see a lot of positivity issues. And then coming to the antibody testings like IgG and IgM. So the window period in that, error or the what errors we see, the window period, because we see the positivity of window period, like IgG doesn't come positive till 14 days. So suppose one patient, like in our case, the patient we do even during admissions, the antibody testing for the convalescent plasma to see like, you know, the potential donor for convalescent plasma and all, antibody testing. So then the window period, suppose the test is done within 7 days, the IgG antibody, and so this comes and, you know, in 14 to 28 days so of the antibody testing. So these are the common holes or common challenges for our RT-PCR, like pre-analytical errors of collection, storage and transport, and antigen test or antibody testing, the window period and collection of the samples is issue.
Yes, I agree with
I have a comment. I have a
Sure,
comment.
Professor, go ahead.
As Dr. Banani has rightly explained that, this RT-PCR is again quite a dynamic test. So this pre-article errors, like, who has collected the sample, do they had the right training or not, and from which area they have collected. Now, when the sample was taken, was the media was okay or not, how it was being transported, and how, it was being stored. And again, the viral load is an important question in that case. So again, I see this is quite a dynamic things to be correlated. And the second point is, again, when we are talking about the antibodies, as per the literature, yes, it is the 14 days after which that, this IgG antibody should develop. But this is, in practical matters, it doesn't happen like this. It is a human body, it is not
It doesn't.
mathematics. So, every patient
Yes.
responding differently. So we also, as a clinician, what we see is important is that how is the important thing is the prognosis of a patient, how the patient is presenting to you, and what we're expecting him to develop further. And again, what was the chest x-ray at that time? I have seen the cases, they are going RT-PCR positive even for the month or maybe more, and they're not
Yes.
developing the antibodies at all. So, how you're going to, categorize all of them. So I see that the symptomatic behavior of a patient and its prognosis as a clinician is more important, rather than, being the fight of being the positive or negative. Yes, the positive can be a factor for, to determine the transmission rate. But yes, again, you may find many patients or even your colleagues, those who are not having even a cough, but you may, find them the RT-PCR positive, or even you may find them the IgG highly positive, growing to up to the level of more than 300. So it's quite dynamic. I see important is the patient and the patient care, and at the last is the outcome.
So because of this, actually during discharge, now our RT-PCR is not done. In India, actually, during discharge
Yes,
initially,
absolutely.
so our
Yes,
RT-PCR is not required.
Okay,
yes,
one
yes,
more
absolutely.
question. Yes, there's more questions about did you see or did you face a infection with COVID, because people start talking about reinfections, or did you face it in India, reinfection with
They are
COVID-19?
very rare, very rare.
Yeah.
There are one or two cases who has reported in newspaper reporting, but we have not seen any in our hospital. So very rare. Personal experience, no.
Okay, and there is another question talking about what does positive PCR mean for post-COVID patient without any symptoms after 21 days of starting disease, because I think the virus stay longer in the
Yes,
nose,
yes.
and it's because the RT-PCR it's like replicate a dead virus.
Dead virus. So because of that, it remains positive further to when patient recovered. So we do, because of that in India, we don't during discharge of the patients, or suppose patients are joining back to the workplace, we don't do the RT-PCR because it remains positive for the longer time.
So you do it once in the beginning for diagnosis, and after
Yes.
that you stop. After like what? You stop after like 7 days, or after the patient is improved his...
No, only during the admission. Now, not during initially that was done at 14 days during the discharge, but now it is not recommended by ICMR. So now only during the admission and during the diagnosis. Like if
Okay.
patient is home quarantine, first time, not repeated any other time.
What about patient in intensive care unit?
Our
Did you...
RT-PCR is not done, not repeated. The other tests are done for the prognostications, but not the RT-PCR.
See, again, the point is the same. Even if the patient is admitted to the ICU, the important is the prognosis of a patient. Once the patient has become the positive and it is having the, the chest infiltration, and is having all the symptoms, the severe symptoms of the respiratory illness and with the comorbidities, then the main aim is, to get the patient treated and coming, getting back to the normal. Getting the RT-PCR done, I'm sure that it won't help much when it is spreading to a large amount of the population. Again.
Questions for myself. Now we are talking about immunity, or people develop immunity after a month of infection. Like we start looking for IgG, and they're talking about spike and immunity. So how long are you testing for serology, and you expect to see the state of your immunity for how long?
We see, like, when we have done the study in healthcare worker, so we have seen, we have done, like, when whoever was positive with COVID-19, even with whoever the healthcare worker, to see the surveillance we have done. So we see the positivity for the longer period. It's not like, how it is given in the graph, like 28 days after, 29 days, it's again immunity is gone. So we have seen for the longer period, the IgG antibody is positive.
Okay. One more question. They're talking about nasopharyngeal swab or oropharyngeal swab. There is some debate which is the more sensitive, or both sides, because when you start COVID, they make both oropharyngeal and nasopharyngeal. What do you think from your experience? What is the most sensitive?
It's if you can do both nasopharyngeal and oropharyngeal, this is the more, like, we see the sensitivity more. But nasopharyngeal, the percentage is around 70%, and oropharyngeal is around 30 to 40%. So this is based, I can't actually quote the actual figure, but there is a JAMA article which quotes the actual figures. But the approximate figure is, like, nasopharyngeal is the better, and then the oropharyngeal. And if patient is admitted in ICU, the BAL as bronchoalveolar lavage is the best rate.
Right.
Have you tested?
Like, for the normal patient is not possible when no this thing. But now,
did you isolate COVID from CSF?
They have started sputum, so they are.
What about CSF? Have you tried the CSF for inpatient internet?
No. We have done for, like, pediatric patients some procalcitonin in CSF, not for the COVID.
No.
Different marker like IL-6 and procalcitonin we have checked, because there are neurological manifestation, and when there is a pediatric multisystem inflammatory syndrome, we have checked for the IL-6 and procalcitonin in CSF, because there were some studies mentioned that, and different autoantibodies in CSF, but not COVID in CSF.
Okay. What antivirus role and treatment of COVID for both of you doctors?
Pardon?
They are asking about what about antiviral role in the treatment of COVID-19.
Antiviral, okay. Now, like remdesivir, like I have said in some of the slides, there are, like, based on the severity, they are giving antiviral, and the response, although there are controversial articles also recently where they have said there is not much role of remdesivir, but personal experience says that antiviral plays role in the treatment of COVID-19.
Okay. I think I'm covering all the questions. We'll give a few if maybe someone want to add some questions since we have the time.
One more question I have received, I think, is there a certificate?
I'm sure there is certificate.
There's
one. Yes.
Yeah. Are you providing?
Yes. The society, they would provide and CME. I think with this huge number, yes, I think it's a really good number of attendance. Sensitivity of serology testing in comparison? do you facing any difference between sensitivity of serology testing? I think the IgG and IgM.
Yes, the sensitivity also depends on, because I missed some of my slides because I was like initially there was some technical glitch. So I wanted to show like, you know, where during the validation plays very important role. Verification and validation plays very important role when this comes about the IgM and IgG. So then comes the role of cutoff verification and precision and accuracy check of all the kits, because in India we have seen like many of the kits from different manufacturer and different IVD vendors. Some are for the spike protein, some are the and some other membrane protein. So there are difference in the sensitivity. So based on the kit, so this is the responsibility of us diagnostician to check the sensitivity of the kits, and based on the IV
Okay.
kits and IV vendors, there are difference in the sensitivity. But I'm sure that there is recommendation from your society and from your government, like, you know, which kits are approved and which are not.
Okay. I think is there anything else before we wrap up? There's one question: if patients after infection completely free, if he is still infectious, like a secondary, I think we are not
talking about reinfections. We have not seen reinfections till now in like, you know, but there are cases, like 1 or 2 cases reported in India, in Mumbai, also in the state where I stay, and also in Gujarat, another state. So there are some newspaper reporting about the reinfection, but as per our personal experience, we have not seen any.
Okay. I think
see, personally I also feel that, you know, I feel that there might be cases of reinfection, but you know, many of the patients are not coming the fear of getting isolated, and in the few states of India it was the matter, like, you know, a person or a patient, if it gets positive, they need to be what we say institutional quarantine. So the patient is, you know, getting fear of going to the hospital. Instead, they feel it better to be at home. So I many of the patients also might be holding the information and getting the reinfection if they have gone through such kind of phase. Maybe they are not coming up. So I feel that what we know may be just a tip of iceberg, because it is the documented reports that we know, but it is just a tip of iceberg, maybe a mini number.
Anyway, we have to get to conclude. It's a very hot topic, and I'm sure that we gain from all your knowledge and your background. I'd like personally to thank you both, and we're sorry for inconvenience what happened with the webinar. Thank you everybody for attending, and thank you Dr. Samia Subki for great webinar and gathering. Thank you so much. Thank you, Professor Bernay. Thank you, Dr. Dali, and hope to meet again near future for another talk.
Yeah, thank you so much.
Thanks a lot for being a lovely participants, and thanks to the organizers. Thank you so much.
And before we end, be safe and stay healthy. Thank you.
Keep healthy. Keep safe.
Yes. Yeah.
Bye. Take care.
And good night from India.
Night. Okay. Bye.